Good afternoon, everyone. Hetal Gohil here from the Medical Services Department of Hetero Healthcare. On the behalf of Hetero Healthcare, I would like to welcome you all to this enlightening webinar on the management of refractory ascites and hepatorenal syndrome, along with the potential role of midodrine. Hetero Healthcare is an innovative pharmaceutical company for more than 3 decades, which caters to 14 plus therapeutic groups aiming to improve patients' quality of life. Hetero is amongst the world's largest manufacturers of APIs and have been majorly involved in tackling national emergencies over the years. This was possible only due to strong R&D team and 25 plus state-of-art manufacturing facilities that ensures seamless supply of medicines. As a solution provider, our prime focus is to always cater to the current needs of doctors and patients for uplifting human life. It has been found that liver diseases are gradually becoming a public health priority in India, which affects around 1 in every 5 individuals. Liver cirrhosis has accounted for almost 2.1% of all the deaths in India, and this increases the risk of liver complications such as portal hypertension, hepatorenal syndrome, ascites, and recurrent ascites as well. Because of all these complications which are arising due to liver cirrhosis, it reduces the life expectancy of the individual. To discuss this further in detail, we have expert with us, Dr. Mithra Prasad from Coimbatore. She is a consultant hepatologist, director of endoscopy, and a course director in DNB program at VGM Hospital, Coimbatore, with a niche practice in hepatology, liver intensive care, decompensated cirrhosis, autoimmune viral and alcoholic hepatitis, and HCC. Her area of expertise include endoscopic varicose bleed ligation, band ligation, post-eviable ulcer bleed management, argan plasma coagulation, hemospray, hemoclipping, colonoscopic polypectomy, and ARCP. She has 15 plus publications in the index medical journals and books. She has been the co-editor of the books named Acid Peptic Diseases and GI Therapeutics. She has also written a number of chapters in national and international books. She has been the part of Unified ACLF Guidelines Committee in the Asia Pacific Associations of the Study of Liver 2024. She's also the member of...
Can I interrupt? I'm so sorry. You can keep that brief. I think we have a long lecture as well.
Okay.
No
Okay.
problem.
Okay, ma'am.
Thank you. Thank you. That's such a
Okay.
beautiful introduction. But yeah, that's perfect. Thank you. Thank you so
Okay.
much.
Okay, ma'am. Over to you, ma'am. You can start with the session. Thank you, ma'am.
So thank you very much, the entire Hetero Healthcare team and Vikrant sir for this. And hope you all have a very informative hour. And please do keep asking any questions that you. So yes, greetings from VGM Hospital, Coimbatore. And today let's just briefly look at drugs in refractory ascites and acute kidney injury, especially targeting HRS, the hepatorenal syndrome. So what are the therapies that we have for refractory ascites? Refractory ascites sets in when the conventional management of the ascites no longer works. So once the refractoriness sets in, we will have to go on to a few extra therapies that are probably a lot of them are still being studied, but some of them really have a good proven benefit. So long-term albumin, newer diuretics, vasopressors, drains, tips, transplantation. You go ahead based on the stage of each person and whether you are looking at a bridge to transplant or a cure. So we will have to individualize the therapy in each patient as well. And in acute kidney injury, more straightforward, the vasoconstrictors, albumin, renal replacement, and transplant. So let's look at definitions so that we really understand our patient really well. So what is refractory ascites? Any ascites that cannot be mobilized, yes, or which recurs really fast. This is called refractory ascites in spite of a adequate salt-restricted diet and medical therapy. So this can be categorized into diuretic resistant or diuretic intractable. Diuretic resistant is when the maximum dose of diuretics are used and still the ascites is not mobilized or recurs early. Diuretic intractable is when you cannot use the maximum dose of diuretics due to some complication or the other. Yeah, looking at the definitions for acute kidney injury and acute kidney disease and chronic kidney disease in a patient with cirrhosis. So we have to consider point 0 when these patients can be completely naked, that is, they need not have a kidney injury at all, or they might have another acute kidney disease or a chronic kidney disease, and then the injury sets in. So once the injury sets in, from day 0 to day 7, we term it acute kidney injury when the serum creatinine rises more than 0.3 milligram per deciliter within 48 hours, or if the serum creatinine has risen more than 50% from the previous baseline, that is the previous 7 days, or if the urine output falls to less than 0.5 ml per kg per hour for more than 6 hours. This is AKI. And CKD is defined when the person more than 3 months still persists to have a GFR of less than 60 ml per minute per body surface area and raw markers of kidney damage. So both these patients have to be handled in a very different manner. And anything that does not fit into either AKI or CKD criteria, we term them to be AKD, especially those who get an injury and which persists for less than 90 days. So the pathogenesis, let's look at the pathogenesis of each of refractory ascites. So at first, when there is cirrhosis and a stiff liver, there is an obstruction to the portal flow, right? And then portal hypertension really sets in. This will cause a shear stress on the splanchnic vessels. So what do the stressed vessels do? They produce more local vasodilators. So this vasodilators causes splanchnic vasodilation, spill over to the systemic circulation, causes a decreased effective arterial blood volume, that the body perceives that you have lesser blood volume, and that's when the various vasoconstrictor systems set in and the hyperdynamic circulation sets in. This as a loop, when it keeps happening, there'll be the development of ascites, preferential localization in the peritoneal cavity, compounded by the fact that there is low albumin as well. And then it also causes a renal vasoconstriction, sodium water retention, and the whole loop causes what we call as HRS2. This is how the whole thing persists as a loop. And to add to all the complications are your additional acute insults that happen, like a viral hepatitis flare, a DILI, an alcoholic hepatitis, or and sepsis, or anything you say can cause the increase in the DAMP and the PAMP, increase in the systemic cytokines, increase systemic inflammation, portal microthrombi, worsen the portal hypertension, and thereby the loop keeps worsening. And that's why these patients from having ascites go on to develop refractory ascites and ultimately chronic kidney disease. So if you see these patients from compensated cirrhosis, as they move on with time, they have ascites, refractory ascites, and when the refractory ascites starts setting in, then you're going to look at the involvement of the cardiac and the renal systems as well, which complicates whatever we can do therapy-wise to help out these people. So what is the pathogenesis of AKI and cirrhosis? AKI and cirrhosis itself is multifactorial. That is something we really have to realize, because using the fancy terminology HRS is like any renal injury coming in, we're trying to put them under the umbrella of HRS. It doesn't work that way, because mostly by the time a patient reaches us, he has multiple compounding factors causing the kidney injury. And each of these, if they're not addressed, you're going to face an AKD or a CKD ultimately. So looking in, once there is a chronic renal hypoperfusion, what happens are a spectrum of diseases that are there at the bottom of the slide. So you can have the patient reverse back to no functional change or no kidney disease at all. You can have people coming in with just HRS AKI. You can have people coming in with acute tubular injury. You can have people coming in with both of these, compounded by sepsis, by maybe bile gas nephropathy. So many things can compound all of these that I think we have to address each of them. So this is one very simple classification that was done in the ICA. You can just look in to see whether your patient has dysfunction, renal dysfunction, or renal damage, or both. So based on that, you will be able to channelize therapies. Let's come into the therapies now. So looking into conventional therapies for ascites, they don't work in these subset of patients. And that's when we call them patients with refractory ascites, right? So looking into therapies for refractory ascites, the best solution, or the one that you should not be missing out on all your patients, is the sodium intake. Doesn't matter if you spend an additional 20 minutes on your patient, please make sure that they are taking the right amount of salt. Any preservatives, anything of the shelves in the supermarket, everything can have salt, and you should not be classifying these patients as refractory ascites. So how do you assess whether there is an inadvertent dietary sodium excess or whether it's refractory ascites? Very simple. So if you restrict the dietary sodium to 2 grams per day, that is 88 millimole per day, and your urinary excretion is still 88 millimole per day, that is the normal ascites, and you can increase diuretic doses and watch whether they are diuretic responsive. Whereas if a patient is taking 2 grams per day but still is not excreting any amount of salt, this second category is when you term them to be refractory ascites, and these people will be collecting around 4 liters, 5 liters of fluid in every week. So these patients should be bridged to large volume paracentesis with albumin or TIPS. And if you're looking at a person who's taking only 2 grams per day and still excreting 176 millimole per day, say definitely he needs dietary sodium restriction. So a simple urine spot sodium should do. So coming on to the other therapies that we would see is prolonged albumin infusions. There have been a number of trials and not many of them did really well, but we're looking at one Preciosa trial that is coming up. So they do use high dose albumin around 1.5 gram per kg per week. And they try to make sure that the serum albumin comes to 3.9. They say if you reach that target albumin, then the fact that you will recollect your ascites becomes much, much better. You're looking at better cardiac function, you're looking at better suppression of systemic inflammation and an ultimate reduction in HVPG. We're still waiting for the trial results. So we're hoping for something that could really be beneficial. But again, the cost of this is going to be very high. So looking at the drugs that come into play in refractory ascites, one of the best and the safest drugs would be midodrine. It is an alpha-1 adrenergic agonist, increases the venous and the arteriolar vascular tone, both. So, and the half-life is around 3 to 4 hours, which is why you need a thrice daily dosing. It can reduce the plasma renin peaks, the plasma aldosterone peaks, and not only on a short term, also on a long term. But the only thing is you should know that it can cause nocturnal supine hypertension. So no dose beyond evening 6 p.m. to be given. And then urinary retention can as well come. This in really high doses have caused systemic hypertension and bradycardia. So make sure when you're having other drugs that could potentially cause bradycardia, make sure your midodrine is doses are adjusted as well. So this study by Shrestha et al. Clearly shows that the plasma aldosterone concentration is really reduced by the use of midodrine, as is the plasma renin aldosterone ratio. Both of these are the targets that we are looking at in this subset of refractory ascites patients. And there have been an N number of randomized control trials. The most, the most highlighted of them all is Singh et al. In 2013 and 14, which showed that not only on a short term, on a long term basis, also midodrine did really well based on as against standard medical therapy. So it did increase the MAP. It did increase the decrease the plasma renin aldosterone ratio, the plasma aldosterone, the and it maintained the GFR and did show a very good hemodynamic improvement, better ascites control even on a long term. So the same things have been reflected in other studies. They have used doses between 5 and 15 milligram thrice daily doses, done really well, very less side effect profile. And so please do consider it if you have a refractory ascites patient with low mean arterial pressure. This is the long-term effects that we find with midodrine. The GFR is maintained, the urine sodium excretion, the plasma renin activity, the plasma aldosterone levels, everything has significantly improved on a long-term basis as well. And then the long-term side effects or the drug-drug interactions are quite minimal for this. So, but then why are we still not able to place midodrine as a singular drug for refractory ascites? Well, it is a very diverse population. There can be more severe disease, more hemodynamic imbalance. There can be elevated cytokines causing a dip in these patients. All of these patients will not respond with midodrine as a solo therapy. So it will need combination therapy with octreotide, terlifelsin, or clonidine based on the scenario, and trials are still underway. So other therapies for refractory ascites that have been looked into, basically we've been targeting every portion of the renal tubule. When the conventional diuretics don't respond, the other two hands that we look into are the SGLT2 inhibitors and the vaptins. So vaptins, very good drugs, but I'm sure a lot of people have mild hesitations to use it. It does work when diuretic intractable ascites there. It's really good in effect. It's really good in correcting the euvolemic hyponatremia, and it does not worsen the hyponatremia as well. It causes a very good weight loss as well. But why are we so worried? Because of this one trial that used vaptins on a long-term basis on a higher dose that caused hepatotoxicity. So the FDA has cautioned that you limit the duration of vaptin to 30 days, remove the indication. It has actually asked to remove the indication of use for patients with cirrhosis, but this is being slightly modified, and be on the watch for liver injury. So we might need to rethink this particular drug. And in cirrhosis, the recommended dose would be 15 to 60 milligram per day for 7 to 30 days, but we don't use it beyond, whereas you could use midodrine on a long term. So SGLT2 inhibitors, again, a new kid around the block, and people are really excited about any new kids. So the upsides, it does not cause any dehydration, even if volume contracted. It excretes water from the interstitial fluid, so ascites is very well mobilized. It inhibits the sympathetic nervous system, the RAS pathway. In addition to all these effects, as against the conventional diuretics, it improves nutritional status, improves glucose metabolism. The EMPEREC trial also confirmed its renoprotective effects. Why are we worried? Because of one thing is UTI in diabetics because of glycosuria, and this one potentially fatal complication that can come in these patients, especially if they're on other drugs like the three-pronged approach, which is euglycemic ketoacidosis, and it does prolong the ICU stay and does cause a high level of morbidity, mortality. So please do be on watch on using this in an elderly patient in the ICU setting. So how about the treatment of AKI? That's about the drugs in refractory ascites. And apart from that refractory ascites, the most definitive therapies would be TIPS and transplantation. But in patients who cannot go for TIPS or transplantations, I think we would have to somehow optimize treatment using drugs. And that's where all these drugs come into play. I would still feel the safest option is midodrine on a short-term, long-term basis in combination if you can. And yeah, so coming on to the treatment of acute kidney injury, well, the vasoconstrictors that you would use would be terlipressin, norepinephrine, or a combination of midodrine and octreotide. And terlipressin, the recommended dose is 2 to 12 milligram per day, but the Indian population generally does not tolerate doses higher than 2 milligram per day. So caution about the side effects that could set in. So norepinephrine, 0.5 to 3 milligram per hour. Trials wise, a little causes a little lesser, better renal perfusion than terlipressin, but still a safer alternative when you cannot use terlipressin. Midodrine and octreotide, a wonderful combination, especially used in the US where terlipressin use has still not come into play. So midodrine, the dose of a little higher dose of 7.5 to 15 milligram every 8 hours to be given in the HRS setting. And the octreotide will be 100 to 200 microgram every 8 hours. So this is all from the guidelines. And the other thing is you really have to understand where your drugs can cause constriction, vasoconstriction, where your drugs, which parts of the circulatory system your drugs can affect before you combine so that you don't overdo or underdo the management. So what are the criteria for discontinuation of therapy from AKI if the serum creatinine falls within 0.3 milligram per deciliter of the baseline, which means a cure, or if there is no improvement in serum creatinine after 48 to 72 hours with maximum tolerated doses, then you're going to consider this patient more for RRT. Or if there is any serious adverse reaction, if you're initiating an RRT due to any reason, liver transplantation. Otherwise, a total duration of 14 days you can give with the vasoconstrictor therapy in an AKI patient. So the dose titration, again, terlipressin, they are saying that you increase the dose by 2 milligram per day every 24 hours and go up to 12 milligram per day, but our Indian population does not tolerate anything beyond 3 milligram per day. So caution on that. Then the norepinephrine dose can be increased in every 4 hours in steps of 0.5 milligram per hour to a maximum dose of 3 milligram per hour. And then the albumin, you're going to combine it with all the vasoconstrictor therapy. You're going to give 20 to 25% albumin at a dose of 20 to 40 gram per day. Warning is albumin, you should not have any fluid overload with this therapy, and please do withhold albumin if there is an evidence of pulmonary edema. So what we really have to understand is in this subset of patients of refractory ascites or AKI and cirrhosis, they're all already burnt out patients. The prognosis is very bleak. So the mortality is pretty high, 20 to 80% in 1 year. There can be recurrent admissions, there can be sepsis, which tips the burden again. And then there can be a higher caregiver burden. The patient quality of life is not going to be good. This is a very fragile and a very difficult patient subset to treat. So in such patients, any drug, the outcome of any drug, you should not look at whether it causes an improvement in survival. We're going to have to look at whether it can, the goal we will have to redefine for these patients. Will these drugs increase ascites-free interval? Will they reduce the frequency of paracentesis? Will they resolve sarcopenia? Will they renoprotect? Will they cause hemodynamic stabilization? And looking at all these drugs with this perspective, these drugs do pretty well. And looking at the side effect profile as well, midodrine is a very good combination drug. I'm sure we will have more studies with combination with midodrine coming up. So I feel all these drugs have to be looked into a light that you actually bridge them either to RRT, bridge them to TIPS, or bridge them to transplant. And if they work good in your patient, I think the outcome of the drug is deemed to be really good. So I know we would really love one pill for any patient, and the doctor's going to be super happy. But not every patient can, tolerate such one magic pill, I think. So it is a faraway dream. And so thank you all from VGM Hospital. And I hope you found the whole lecture, light and really informative. Thank you.
Thank you so much, ma'am, for the very insightful and informative session, giving brief idea on all the drugs which are being used for the management of HRS and ascites. The question which we have received are, what are the parameters or the vitals we need to consider when the patient is on midodrine? How to monitor a patient who is on midodrine?
So the parameters you really need, see, most of your patients are going to have a low MAP. So you set the target MAP to be 60 to 65. There's not much monitoring that midodrine needs, but you will, if you're using it in a patient with normal MAP, which we don't generally do, then you're going to be looking at systemic hypertension that can be mainly dose related. So that we have to be cautious about. And the other thing is, if you're having a patient who already has bradycardia, but apart from this, I don't think there are any much vitals to be monitored when you're on midodrine. So all of these are dose dependent effects. At the dose that we use, 5 milligram thrice a day and then taper it up, or 7.5 milligram thrice a day, none of these side effects you're going to be looking into.
Okay, okay, ma'am. And what is the maximum dose of midodrine which can be utilized?
So for cirrhosis, studies have shown good effects with doses till 15 milligram thrice a day. So you can up titrate till that, but be cautious you're using a higher dose, so the side effects might set in as well. So if you can monitor them, then 15 milligram thrice a day is perfect. We usually find effects right with 10 milligram thrice a day itself.
Okay. And what will be the initial starting dose when you just start prescribing midodrine?
We start prescribing it at 5 milligram thrice a day, depending on whether you're using it to prevent HRS2 setting in or in refractory ascites. And in a patient with AKI, you will be using it at 7.5 milligram thrice a day.
Okay, okay. So how to manage refractory ascites in presence of associated comorbidity of hypertension?
So, yeah, as I said, all these patients really need to be subcategorized. And then hypertension and refractory ascites, I would still say, please look into the salt content in this patient. Please look into whether he has an additional CKD itself causing this, because otherwise, any patient who is a full-blown cirrhosis with refractory ascites should be generally having a low MAP. So all your in these patients, your SGLT2 inhibitors would be a welcome, and would be the best therapy that you would use. But again, given the antecedent complications that SGLT can use, you would need to monitor them more closely.
Okay, okay. Um, uh, if you compare noradrenaline versus terlipressin, how they will be good at? I mean, what are the outcomes when you compare these two drugs and when you compare these two along with midodrine?
So, noradrenaline and terlipressin. See, we use norad, terli, and midodrine. If we are using it in a common scenario, it would be AKI. So in AKI itself, the renal perfusion at any map increases better with terlipressin rather than noradrenaline itself. So if you find a patient compatible and totally would be safe with terlipressin, given the cardiac or the all the other side effect profile of terlipressin, if you feel your patient would be able to tolerate it, go for terlipressin first. But if you need a patient who would need, who's still, say, hypertensive, or you have a patient with sepsis or other complications where NORAD would really help, I would say you could use noradrenaline as the vasoconstrictor of choice. And midodrine could be a combination with either of these and albumin. So you could try a three-pronged approach in these
Okay.
patients. Midodrine will do good as an add-on. So I doubt it would, there are any good RCTs to say that it can either replace NORAD or terlipressin, but it will do good as an add-on
Okay.
in
So,
combination with albumin. Yes.
okay. So, in your opinion, midodrine alone is not effective, or it should always be combined with these agents?
Depends on whether you're looking at an acute scenario like AKI, or whether you're looking at something that, more an OPD kind basis treatment like refractory ascites or type 2 HRS. In which case, in refractory ascites and HRS, we don't have other options, and midodrine does very well as well because we need oral options. But when you're looking at a patient who is in the critical care aspect, it will only be an add-on drug.
Okay. Okay. Um,
Because we need other mechanisms to improve the renal perfusion rather than just midodrine. So that's the reason. So it can
right.
be a very good add-on drug because of its amazing side effect profile and because it can synergistically help with all these drugs.
Right. Is midodrine effective in hyponatremia as well?
See, you're asking me whether midodrine, theoretically, it should be. But I don't know whether the action is strong enough to reflect clinically. But you can use it in hyponatremia without any complications for sure. So
Okay.
we
Okay.
don't actively treat hyponatremia until and unless we need to, but midodrine can be safely used even when the patient has hyponatremia. That's not an issue.
Okay. Okay. Midodrine has considerably, I mean, it increases urinary sodium excretion, but after 1 and 3 months of therapy, this effect is no longer seen, or even after 6 months. So,
You're
what
talking about
parameters
urinary
to be taken
sodium
into account?
excretion due to midodrine.
Yes.
Um, see, um, see, it's again theoretical because it's acts on the JGA as well, juxtaglomerular apparatus as well, and then prevents renin as well. But just that focus of just that area of renin secretion can only alter things only so much. I think these subset of patients have things going on in every system, every hemodynamic
Yes.
system in the whole body. So I don't think focusing just on the JGA, theoretically, it might seem amazing, but it being able to, cause sodium excretion or not, or all of it is not going to clinically affect anything too much because you have
Okay.
a lot of other factors being interplayed. And right now, focus is shifting because we've exhausted the renal part of it. We've exhausted the conventional loop diuretics, the aldosterone agonists, the vaptans, the SGLT2s. And apart from this, the midodrine, we have to look into additional agents that can target the cardiac as well, because the heart also seems to play a major, your ANP, BNP, all of this seems to play a major role in this subset of patients because of the hyperdynamic circulation and the underperfusion that happens. So something that powerful that can target the entire RAS would be a blessing, but I don't think midodrine is quite there yet at these doses.
Okay, okay. So PICD is the complication of LVP, and there are certain literatures which say that midodrine is also effective in preventing PICD. So what is your take on midodrine use in PICD?
No, that's absolutely true. So I'm sorry, I couldn't get slides on that, but PICD is a complication that can really be taken care of well by midodrine and albumin together. So again, since it can reduce the PRA, the plasma aldosterone concentration, all of it, midodrine does prevent the occurrence of PICD itself in this subset of patients. So that's it. The refractory ascites patients, you really have to give them midodrine unless otherwise it's contraindicated.
Okay, okay. So ma'am, with these were the queries which we had received from the doctors, and ma'am, you can just summarize the entire session. It would be helpful for us.
Oh, yes. So, in summary, we are looking at a very fragile subset of patients. These are not the conventional patients that respond to conventional therapies. And when your cirrhosis patient reaches such a stage, so be aware that additional systems are getting involved, like the cardiac or the renal as well. And try to, I think we have to think beyond being a hepatologist or a gastroenterologist. We'll have to think from the cardiac perspective and from the nephro perspective as well. Always better to make it a multidisciplinary approach so that our goal should be to bridge or delay the occurrence of refractoriness or worsening hemodynamic profiles and setting in of renal complications that are irreversible, or safely bridge them across to transplant. So in all of this cannot be done by a single drug. It will need the right combination, and anywhere where you use combination drugs, you really have to watch out for side effects as well. But definitely, there are drugs like endothelin receptor antagonists that are coming and endothelin receptor agonists that are coming in. So these all will come into combination therapy. And with midodrine as well, you will be finding a lot of combination trials that will change the scenario for these patients so that they are not continuously in the refractory ascites in say the SIDS or the CARS component. They're not sarcopenic and they're not presenting with recurrent SBPs. So ascites mobilization is really important in these patients, because the more and more you can keep these patients dry, the lesser the onset of recurrent SVPs or ACLFs in this patient, the lesser you're going to face MDR infections in these patients. There's so much that we have to bridge these patients to transplant itself. And yes, as I did the whole base research, I found that these drugs do meet a lot of great outcomes. But if you're going to look at just survival outcomes for these drugs, that's not going to be there, because these patients have a lot more going on in them. But if you look at how they can stabilize these patients, these drugs do amazing. And I think midodrine is a drug that really does meet whatever its targets. It does really well. So again, thanks so much to Hetero Healthcare for this opportunity. And yeah, I hope you really found the whole thing useful.
Yes, ma'am. Yes. Thank you, ma'am. Vikrant, over to you.
So
Vikrant
thank
sir.
you, ma'am, for this wonderful session. It was really amazing, and we are really thankful. Despite of your busy schedule, you have accepted this invitation and given this wonderful, insightful presentation, which is not only thought-provoking, but has also enriched our entire audience understanding on management of refractory ascites and HRS. Thank you so much, Mithra ma'am. I would also like to express our deep appreciations to all participants, attendees for their gracious presence despite of their busy schedule. And thank you for your active participation and such engaging questions. I would also like to thank our Senior Vice President, Sir, Mr. Nehru Dadi Sethi, sir, for his generous support and guidance for the webinar. Uh, at the same time, I also appreciate the efforts of entire our dedicated organizing team, our sales heads, our field force, especially Mr. Venkatesan. A wonderful support being extended by him. At the same time, our medical advisor, Ms. Hetal Gohil, our IT team, our entire PMT team for their exceptional efforts and attention to details. The entire scientific session was sponsored by Hetero Healthcare, makers of MidoHep. As we conclude, we hope you leave with new insights and learning. Please feel free to reach out to us or our team members for any feedback or further questions. We look forward to welcoming you to our future events. Thank you once again, Dr. Mithra ma'am. It was really a wonderful session. Thank you for your gracious presence and participation.
Thank you so much. Thank you to all the participants and thanks to Hetero Healthcare. Thank you.
So much. Thank you.